The thyroid gland is a butterfly-shaped gland in the anterior portion of the neck. It is held together. The right lobe and left lobe are held together by a connecting portion called the isthmus. Looking at a coronal section here, we can see that the thyroid wraps all the way around the trachea. So it's not just this butterfly-shaped gland from the anterior view, it also wraps around posteriorly towards the vertebral body. At the back, in the posterior region, you will also find the embedded parathyroid glands, which are not technically part of the thyroid, even though they are housed there. The parathyroid glands are part of their own calcium regulating system, but are embedded within the thyroid and look identical to thyroid tissue. What you see down here is an uptake scan. One thing that makes the thyroid gland different than other things in the body is that it utilizes iodine. This is an iodine uptake scan, and where you see the dark colors, that is indicating that iodine is being taken up by cells and utilized by those cells to make thyroid hormone. So if we trace this, we can actually find the shape of the thyroid that is indicating normally functioning thyroid cells taking up and utilizing iodine. Welcome to this talk where we will be learning about the quick and dirty anatomy and physiology of the thyroid gland. Because the thyroid is making hormone and also receiving hormones from higher brain centers, it's important that it have vascularization, have a blood supply. It receives blood through the superior thyroid arteries, and it is drained of blood by 3 sets of veins, the superior, middle, and inferior thyroid veins, which carry thyroid hormone from the thyroid to the rest of the body, where that thyroid hormone can bind and have an effect. You'll also find that besides having rich vascularization, the thyroid is also associated with a lot of innervation, specifically sympathetic or sympathetic nervous system fight or flight innervation. It has close association with the superior cervical ganglion of the sympathetic trunk and also the middle cervical ganglion of the sympathetic trunk. Remember, the ganglia are where the nerves coming off from the spine stop and pick up with the next neuron in line called the postganglionic neuron. And the fight or flight sympathetic nervous system helps activate parts of the body to engage in stress. So it encourages the heart rate to speed up, the force of cardiac contraction to go up, the blood pressure increases, oxygen utilization increases, the bronchi dilate. We start to break down stored glycogen into glucose. So essentially, we are preparing the body for enhanced activity or physiologic stress. So that tells you when the thyroid is activated, it will have sympathetic activity because of this innervation. The functional unit of the thyroid itself at the cellular level is called a follicle. And the follicle is just a functional unit. It's spherical in shape, and it's surrounded by epithelial cells. There is a capillary, not a supple, a supply associated with this so that it can pick up hormone and also deliver hormone. Epithelial cells are interspersed with what are called C cells, and in this case, C is for calcitonin. C cells release calcitonin, which is working together with parathyroid hormone in calcium regulation. Back to just our thyrotropic cells, though. Our thyrotropic cells, things that will make thyroid hormone and can be stimulated by thyroid stimulating hormone. These thyrotropic cells surround this colloid. The C here is for colloid. Colloid is a thick gelatinous substance where we have the storage of the precursor for thyroid hormone called thyroglobulin. So colloid physically is this substance, this watery gelatinous substance that contains thyroglobulin. Thyroglobulin can be modified into our thyroid hormone, T3 and T4. So this is your follicle. We have our cuboidal epithelial cells, which include some C cells and some thyrotropic cells. We also have capillaries here. We can see the red blood cells have been labeled. But at the center of these follicles lies the colloid, which contains our thyroglobulin, the precursor for thyroid hormone. What we see here is an illustration of our butterfly-shaped thyroid gland, and this illustration is orienting you to follow the specific thing that is utilized by the thyroid that is not utilized by any other part of the body, and that is iodides. And iodides, which generally come from the diet, iodides are transported into cells of the thyroid. And in this process, iodides go through a series of reactions until they are incorporated in this precursor substance called thyroglobulin, a large globular protein linked to T3 and T4, our two thyroid hormones. Thyroglobulin is what lies in the colloid. When we receive the message that the body needs more thyroid hormone, we need to break off, so break down through proteolysis. Lysis meaning to break apart, proteo meaning protein. So through proteolysis, we break down thyroglobulin into our active thyroid hormone T3 and T4, which will enter the bloodstream. T3 and T4 will make its way out into the peripheral tissues, and different substances will eventually modify these into T3, which has the most biologic activity in the human body. Certain things can interrupt this conversion of T4 to T3, like beta blockers or cardiac medications. But one thing to take away from this illustration is that iodides are necessary to not only make thyroglobulin, but they're necessary at various parts of this cascade so that we can have adequate production and release of thyroid hormone. Again, where do iodides come from? They mainly come from the diet. Most salt is ionized, meaning that table salt contains iodide within inside of it. So generally, we see that Americans are consuming far more than what our body actually needs to work at a basic level. So we're generally ingesting about 400 micrograms per day, and that amount is either stored in the body and utilized by the thyroid, or the bulk of it is just going to be excreted through the urine. What you see is that adults need at minimum 150 micrograms, kids about 90 to 120 micrograms, and pregnant individuals 200 micrograms per day. So because American citizens are having so much more iodide than they need, it is pretty rare to see true iodide deficiency driving thyroid problems. We can find this iodide that's been stored, concentrated in the thyroid, the salivary glands. There's different gastric glands, tear glands, breast milk producing glands, and also the choroid plexus, which is up in the brain and is associated with cerebrospinal fluid. About 70 to 80 micrograms from the pool of stored iodide is taken up by the thyroid every day, and about 75% of what's taken up by the thyroid is released as thyroid hormone. So we absolutely need iodide to manufacture and then release thyroid hormone. Before we had iodized salt, goiter used to be what we call endemic. When there's low iodide in the body, that will lead to low levels of thyroid hormone, like T4. When levels of T4 are low, it will tell these areas in the brain, the hypothalamus and anterior pituitary, that we need more thyroid hormone. And so the hypothalamus will make lots of its product called TRH. And in response to that, the anterior pituitary will make lots of its product called TSH. And that TSH is a substance and it needs to bind to a receptor. And where do we find receptors? We find them on cells, on the membranes of cells. And if we have a ton of product that's being released, we're going to need a ton of receptors to bind it. So in the case that there's a lot of stimulation to the thyroid to make thyroid hormone, the thyroid gets really big. It needs to have more cells housing more receptors to deal with all of this extra message, this extra binding of hormone. So if we have low levels of iodine, we'll never have adequate levels of thyroid hormone. So we'll have this continual feedback cycle encouraging more released. If, however, we have sufficient dietary iodine, we'll have nice normal blood levels of T3, T4, or thyroid hormones, which will signal to these areas in the brain that everything is good and okay, and we will only have release of those two products when the levels of thyroid hormone fall beneath homeostatic levels. When I speak about T3 and T4, our two thyroid hormones, they are so named because of how many iodide atoms they contain. T4, or thyroxine, contains 4 iodide atoms, whereas T3, or triiodothyronine, contains 3 iodine atoms. So that's where the names T3 and T4 come from. Again, in humans, T3 has the largest biologic activity. Whenever T4 is around in the body, there's various enzymes like deiodinases, enzymes that take off an iodine, which will turn T3 into either an active or inactive form. When there are cases of low iodide, in that somebody is consuming low levels in their diet, the body tends to favor formation of T3 over T4. T3 is 3 times as potent, which means its strength, so 3 times stronger than T4, because T4 has to be modified into the active T3, whereas T3 is active right away. It can go bind to tissues and have thyroid type effects. Here we are speaking about how T3 and T4 travel throughout the body. They generally travel around the bloodstream bound to protein, which is going to enhance their length of action, because the longer they're bound to protein, the longer they can hang out in the bloodstream. Only small amounts of these hormones actually circulate free or unbound. About 0.03% of T4 is free in the body, and 0.3% of T3 travels free in the body. And again, T3 is what is biologically active. So in order for T3 to go and bind to a tissue, it has to remove itself or pop off of the protein so that it can go enter the tissue. And what you see in this picture, it's an electromicrograph image of our follicles. So we see our cuboidal epithelial cells, and this black area I drew the arrow to is our colloid. In the second picture, it's pretty cool. When we have stimulation by hormone release from the pituitary, we drive the follicles to actually contract. So we see the active colloid being put into vesicles so that we can break our T3 and T4 out of or off of those protein matrices and then released into the bloodstream. Because iodides are so critical in the formation and release of thyroid hormones, we really take advantage of the fact that Nothing else in the body uses iodine, and it's critical in the thyroid. So we utilize this a lot in pharmacotherapeutics. We can make iodine radioactive so that when iodine is infused into the body, the radioactive iodine destroys cells. And we might want that in the case of a hypertrophic thyroid. We might want to destroy some of those cells so they stop making so much thyroid hormone. We can also, like in the picture we saw at the beginning, we can give infusions of iodine for cells of the thyroid to take up so that we can look at and physically visualize how well the cells of the thyroid are working to manufacture thyroid hormone. Where we saw that darker gray picture of the thyroid in that scan, we were looking at cells that have taken up iodine and are busy making thyroid hormone. Also, a fun fact is we have really high doses of iodine available, and these are given in the case that somebody has a really hyperactive thyroid. Maybe they're undergoing a thyrotoxicosis crisis or a thyroid storm. Or maybe they just have Graves' disease and they're making too much thyroid hormone. One thing that can be done is you can give them a big whopping dose of iodine. So this is interesting, right? If iodine is necessary to make thyroid hormone, why is it that if we give a really big dose of iodine for a couple of weeks, we suppress all steps of manufacturing and release of thyroid hormone? Why? Why does that happen? Well, the answer is we don't know. So the two people who first watched this happen are named Wolf and Chaikoff. And they named this effect of giving iodine in large doses and having that large dose of iodine temporarily halt thyroid function is called the Wolf-Chaikoff effect. We don't know why that happens, doesn't make sense, but it does happen, and that gives you a nice therapeutic to stop all thyroid hormone release and manufacturing for 3 weeks about so that you can figure out what else you're going to do to treat that hyperthyroid patient. Again, this is how we can use iodine in imaging. This is an uptake scan. So this is using radio-labeled iodine. So it's not fully radioactive. It's just a little bit of labeled iodine so that we can visualize iodine uptake in a scan. So this first one is a normal thyroid. So those cells have taken up iodine and they are busy making a normal amount of thyroid hormone. Here in Graves' disease, which is also called diffuse goiter, which is a very hypertrophic, enlarged, and hyperactive thyroid, we see not only a large thyroid, but also very dark coloring, indicating that these cells have taken up a huge amount of iodine that they're using to make lots of thyroid hormone. We can also look at different manifestations of disease where we see hyperfunctioning areas of the thyroid, maybe benign growths, like an adenoma, maybe a toxic nodular goiter, so just a hyperfunctioning nodule. One thing I always tell students to remember is when you see these areas of large activity with dark colors, those are called hot spots, and that tells you that there is a lot of activity, which is typical with benign growths. Benign endocrine growths usually just produce a lot more of whatever hormone that gland makes. Whereas a malignant growth, we would not see it doing normal thyroid things. We would see that there's areas of no uptake, like there would be an area here where there's no thyroid uptake, and we would call that a cold spot. And seeing a cold spot is an indication that that thyroid growth is malignant. So it is 10 times more likely to be cancerous than a hot spot. I would like you to think of thyroid hormones as metabolic in nature. They increase metabolic activity in cells, and that activity is thermogenic. It generates heat, so body temperature goes up, body heat goes up, metabolism levels go up, so how many calories you need to undergo your activities. It increases catecholamine binding to receptors. So beta receptor activity goes up, heart rate goes up, stroke volume goes up. Cardiac output is heart rate times stroke volume. That goes up. Blood pressure goes up. GI motility and secretions increase, so you can see hastened movement of things through the GI tract. You see an increase in brain activity, neurogenesis, synaptogenesis, so the formation of new synapses between neurons. More myelin is made, dendrites branch, sympathetic activity goes up. We make more skin cells, we grow, hair grows, nail grows. So all of these things are increased with thyroid hormone. So you will see that in pathology, the things that are affected will be cardiac related, skin related, metabolism related. Thyroid hormone is critical to growth and activity and metabolism. This is just a simple graph showing you your resting metabolic rate, so how you utilize energy, and that level is going up when we look at level of thyroid hormones down on the x-axis. So as thyroid hormones increase, we also see that metabolic rate increases. So T3, T4 are thyroid hormones, are metabolic. The more we have in circulation, the greater the metabolic rate. Thyroid hormone is under the control of a larger axis system, meaning that it involves the hypothalamus and pituitary. In the case that the body requires more thyroid hormone, meaning homeostasis is disrupted, we have the activation of this system. It begins with production of a releasing hormone from the hypothalamus called thyrotropin releasing hormone, or TRH. Releasing hormones are what come from the hypothalamus, which is a substance. TRH binds to receptors in the front or anterior portion of the pituitary gland, also called the adenohypophysis. And those receptors in the anterior pituitary bind TRH, and in response to TRH binding, the pituitary makes a tropic hormone called TSH, or thyroid stimulating hormone. Thyroid stimulating hormone is named for exactly what it does. Thyroid stimulating hormone binds to receptors in the thyroid gland, and in response to that, the thyroid is stimulated to make thyroid hormone, T3 and T4, which will then have metabolic effects in the body. When levels of T3 and T4 are nice, normal, homeostatic levels, they will provide the shutoff or the negative feedback to the hypothalamus and to the pituitary, telling the body that we need to shut off. Remember, negative feedback decreases in activity. If you tell me these videos suck, I'm going to stop making them. That's negative feedback, right? So when the hypothalamus receives the feedback that T3 and T4 levels have been restored to homeostasis, the hypothalamus is going to turn off this loop by making a little bit of a different product. Instead of TRH, it will make TRIH, thyrotropin release inhibiting hormone. And thyrotropin release inhibiting hormone is an antagonist. It will bind to receptors in the anterior pituitary and stop further stimulation of the pituitary so that we stop TSH release. So make sure you understand that loop. You will understand a lot of your clinical medicine and physiology in general if you remember that TRH comes from the hypothalamus, that stimulates the anterior pituitary to make TSH, and that TSH stimulates the thyroid to make T3 and T4, which will continue until we get to homeostatic levels. The T3 and T4 will work to provide negative feedback to shut off this system. And that, my friends, is your short story of the thyroid. Stay smart.